Hey guys, it's been a little bit since my last JG Extra, but I thought I'd try to get one out today. This one's just a quick one on coughing kids and nasty fingers. For the first part, big credit goes to the MRAP from July and August 2014. Rob Orman and Andy Sloas did a two-part lecture that probably took around an hour and 10 minutes or so combined on bronchiolitis. So I thought I'd kind of just condense it for you in around 9 or 10 minutes so you can listen to it, get a quick reminder, since especially you're probably seeing a lot of kids in the PZD with this. So jump right into it. As far as diagnosing bronchiolitis, remember you don't need to get anything special for this. It's a clinical diagnosis. The big signs and symptoms are going to be cough, wheezing, congestion, probably decreased PO intake, fever, and the big thing is going to be lots of rhinorrhea. Remember, you do not need a chest x-ray for this. As far as RSV testing, this is not needed. Remember, it's clinical diagnosis. If you're wrong, they probably just have a cold. They mentioned that if they look horrible, you're probably going to do the LP anyways, if that's what you're worried about. And the time that it could be useful in the RSV testing is if you have an infant who is around 2 to 3 months old and you're trying to search for a source of infection. Doesn't seem like an obvious meningitis, and you feel like you don't want to tap them because it doesn't like I said, doesn't look like an obvious meningitis. You can send on RSV tests, and they've shown this paper down here, risk of SBI in young febrile infants, that if the RSV test is positive in this case, that they have a very low risk of a concurrent serious bacterial infection, so you can rest easier and diagnose them comfortably with just bronchiolitis as the source of their fever. In the ED, they mentioned the mantra score suck score, which we'll talk about in a little bit for treating them. They said that you can try treating them like asthmatics with as far as bronchodilators. If they respond, then you can continue treating them as such with the addition of hydration and suction, since those are going to be the big things that we'll talk about in a little bit. And if they seem like they're going to need intubation, they're looking pretty crappy, you can just skip the bronchodilator. Go to your racemic epinephrine if you want while you set up for your intubation. As far as using scoring systems to decide who to admit, there are a few. One example is the Wang scoring system. But instead of this, they said that you can actually just ask the following clinical questions. Big one is going to be, are they retracting? Do they have big increase in their work of breathing? Those are probably just going to need admission. If they're very tachypnic, they'll also probably need admission. And the other thing is if they're feeding poorly, obviously they'll need admission for feeding and hydration. If the patient is taking in less than their usual PO intake at one feed, parents will obviously be concerned, but this is okay as long as the parents are remembering to feed them more frequently. You can tell the parents that if their usual intake, an example is 4 ounces 3 times a day. If they're only feeding 2 ounces, that's okay as long as they just feed more frequently, about 6 times a day, to make up for the total intake that they normally get. As far again as DISPO, there are some kids who, when diagnosed with bronchiolitis, they may look decently okay for having this disease process, but they still need to be admitted because they do have a high risk for apnea. And there are 4 babies that this paper lists. The first one is full-term babies who are less than 1 month old. The second is premature babies who are less than 48 weeks post-conception. The third is parents or physicians witnessed an episode of apnea. And the fourth is any kid with one system down, quote unquote. And this is a kid who at baseline may have something like cystic fibrosis, some kind of congenital heart disease, and now they have bronchiolitis on top of that. These and the other 3 examples are kids that you diagnose with bronchiolitis, they look decent, you call the hospitals and get them admitted anyways because they have a high risk for just being found not breathing, probably dead. So as far as things to do at home, the parents are probably going to ask, what can you prescribe them that's going to cure this? Unfortunately, nothing. It's just going to be symptomatic treatment. There is no specific cure. And parents just need to get comfortable with. They're just going to have to give them some time to get better. Suctioning is going to be the most important thing for these kids. Remember that obviously infants can't blow their nose. They're obligate nasal breathers, and this is going to be why they're having difficulty. You do need to tell the parents that they need to be continuously assessing their hydration status. one concern they may have is they're making a lot less diapers than usual. I'm sure some of you have probably heard Dr. Maldonado say at least 3 wet diapers per day is fine, even if they normally make 8 or 10. 3 is a decent hydration status. If they're making less than that, then those are probably kids who need to come in for hydration. So what do they mean by this score thing? Earlier they said that kid comes in, diagnosed with bronchiolitis. As far as deciding whether or not to keep them or send them home, you can calculate their initial severity score if you want, or you can just kind of clinically look at them and say how bad they look. The big thing in the ED to do is perform suction. Get your respiratory tech to do a lot of deep suction with that long tube. Get it down, get a lot of that mucus out, and then you can calculate or just clinically see how they improve. The parents will probably still push. What else can they do? And you just have to reiterate, suctioning is going to be the biggest thing. But one thing that can help the process is putting saline drops down the baby's nose. And if they put a few drops, they can't get an immediate return of everything they put in. It's okay if they can't suction out a lot immediately. The drops will probably just trickle down, and it'll make the baby cough and bring the junk up, and they'll either swallow it or spit it out, which is either way good. Unfortunately, some of them can have a little bit of vomiting because the mucus can make them a little bit nauseated, but either way, they'll get the stuff up and kind of open up their airways again. So as far as telling them how frequently to suction, they recommend at least about 4 times a day. Easy way to remember it is just breakfast, lunch, dinner, and before bed. Do the suctioning, and if they want, they can do a little bit more after that. As far as Afrin, Dr. Sloas recommends, or doesn't recommend, but he says that he actually does give this if something else is needed. This is kind of something I guess you can kind of decide whether or not you want to incorporate into your practice. Some parents may ask if they can get a humidifier. Humidifiers have not been shown to help, but they have not been shown to be harmful either, so if they really want to, you can tell them sure they can try that. As far as prescribing albuterol, it's not required in the ED. Like I said earlier, remember you can try to see if they kind of respond like an asthmatic, and if they do, well, you can probably prescribe it. But the big thing is, remember, this is an upper airway obstructive process. Albuterol is kind of designed for a lower airway, but if the baby's starting to wheeze, then it's probably turning into a lower airway process. And if that's the case, 25% of the kids will benefit from albuterol, but the rest of them, if it doesn't do anything, then at least it won't harm them. So you can decide whether or not you want to give the the albuterol. In late October 2014, there were some practice guideline that came out by American Academy of Pediatrics. Good paper. It's a little bit long, but basically the main points are: you don't need to do a lot of things that people were doing in the past. And this is a little bit in contrast to what Sloas and Norman were talking about. As far as they said, they recommend you do not need to give albuterol or epinephrine. In the emergency department, they recommend not giving hypertonic saline. It is okay for hospitalized patients. They recommend no corticosteroids still. No need for oxygen if they're saturating more than 90%. They don't need to be on a continuous pulse ox. They don't need chest physiotherapy. Obviously, they don't need antibiotics. And obviously, if they're not hydrating well, then they need to come in for NG or IV fluids. So that's it. Just a quick update, like I said, on bronchiolitis. And then the other thing, I had a patient with a finger infection the other day. So just a quick reminder. An example here is a patient comes in and says that, hey, my friend had an infection, that she looked at my finger and said, I had an infection kind of similar to that. And she had hers cut open, and a few days later she was better. I was wondering if you could cut mine too. So you say, okay, sure, let me see your finger. And it looks like this. So you can pause, take a quick look at the picture. Okay, and hopefully decided that you do not want to cut into this, because this is actually herpetic Whitlow. It is not a paronychia. This is in kids, most commonly caused by HSV1, especially if they are getting gingival stomatitis and they're putting their fingers in their mouth. Now they get it on their digits. In adults, it can commonly be caused by HSV2, and so healthcare workers like us, we want to be careful, wear your gloves, because you have a higher risk of contracting it when you're examining your patients. We'll complain of burning and pruritic sensation, like other herpes infections. There'll be erythema, tenderness, and the big thing here is that there'll be vesicular bullae present. So the reason you do not want to cut into herpetic whitlow is because it can lead or it can cause a bad secondary bacterial infection and prolonged healing. So the treatment for this, just tell them, sorry, I can't cut into this. It's not going to be a good if we do. I can give you some pain medicine, and you can plus or minus antiviral. This is the example of the friend, what they had, probably, that this is okay to cut into. A paronychia, you can see, looks like some fluctuant areas on the side of the nail beds. Most common causes are going to be nail biting, sometimes from manicure or hangnails. Staph and strep are going to be the common bacteria causing this in the immunocompromised candida. There'll be a small area that starts to get erythematous, indurated, tender. If you do not feel an area of fluctuance, then it doesn't really seem beneficial to cut into it. So for this, you can just recommend to them warm soaks, elevation. Tintinelli says plus or minus antibiotics. If there is an area of fluctuance, then go ahead and cut into it. And again, plus or minus antibiotics. So that does it for this JG Extra. Thanks, and hope you guys have a happy New Year's.